Thank you, sir, for giving me this opportunity. Yes, actually, this is, though it is a sponsored session, but I will also share some of my experiences and the real world data from our settings as well. So definitely, we need to choose important treatments which are required in some journey of the patient. I always suggest and in my patient that urothelial cancers are somewhat like small cell cancers or neuroendocrine cancers, where they will respond to immunotherapy treatment with platinum-based chemotherapy very well, but they will develop resistance to it very fast, and they will progress rapidly. So that is what happens in the real world scenario. And believe me, more than 50% patients are not able to receive next line of treatment. So that is the main problem. Besides having very aggressive disease, this is the real problem. So let's move to the next presentation slide. Yes. So if we see the timeline of improvement of treatment, yes, cisplatin has been there from 1970s. As for any treatment, platinum has been the standard of care. MVAC came in 1980s. Then combination treatments with gemcitabine came from 2008. Later, pembrolizumab came for cisplatin eligible patients, and later for PDL1 positive patients. And avelumab came in 2021, and it was a game changer. And it is approved as a monotherapy as a maintenance first-line treatment options for patients who had not progressed on first-line platinum-based treatment. Next slide. So that is very important to understand. This is what I was telling about. This was my personal experience. Now, the data from various countries, not only India, is suggesting that there is significant attrition rate. You can clearly see a very small number of patients are able to receive second line or third line treatment. You can clearly see it is to the tune of 35 to 32% only receiving second line treatment, and some patients are not able to receive third line treatment at all. So that is what happens in the real world scenario. It is very difficult. The disease is really very aggressive, and at least 50 to 60% patient cannot receive second line treatment. Therefore, don't think that after platinum based treatment, when the patient will recur or progress, then you will give the next line of treatment, because you might be losing the patient directly, because patients will be presenting a poor performance status where you won't have any option other than giving supportive care alone. So that is an important point from my side. Next slide, please. So majority of the patient can receive platinum based treatment. Eligibility is around 50%. Ineligible is again 50% in the real scenario. And carboplatin based treatment, around 75% patients of cisplatin eligible can receive carboplatin based treatment as per the physician discussion. And you all know about these performance status, renal function, presence of neuropathy, especially in our patients where there is a huge prevalence of diabetes, patients age with reduced glomerular filtration rate. Thank you. Next slide. So this is very important because platinum ineligibility. If we see our own data, we have published our own data from TMH Mumbai. Around 40 to 50% patients are cisplatin ineligible in the real world scenario. And that is what the data is echoing from various countries as well. Various published data, even from the West, is suggesting the similar data. And in our patients, because the patients are presenting in older age and they have already poor performance status of PS2 and a large number of patients, definitely it becomes very difficult to utilize cisplatin. But yes, still a large number of patients can be given carboplatin, and that is why in our experience most of the patients receive carboplatin based treatment in actual practice. Though we know cisplatin is somewhat better than carboplatin in this scenario, and our experience is also same, but cisplatin will be reserved for patients who are fit, having good GFR of more than 60 ml, without peripheral neuropathy, and cardiac functions are completely normal, because cisplatin requires a significant amount of hydration. So the conclusion of the survey, which was presented this year in the defining platinum eligibility, any patient with metastatic urothelial cancer meeting any of the 5 parameters should be considered platinum eligible. That is performance status 3 or more. Creatinine clearance less than 30 ml per minute. This is for carboplatin, because below 50 we do not utilize cisplatin. In practical experience and our traditional teaching from our parent institute, between 50 to 60 ml per minute we give fractionated dose of cisplatin divided in day 1 and day 2. And below 50, you don't give cisplatin, and we utilize carboplatin-based treatment. Patients having peripheral neuropathy, most of the patients have diabetic neuropathy at presentation, grade 2 or more. Heart failure class of NYHA more than 3, PS2 with clearance of less than 30, these are also platinum eligible. So these criteria is very important in the real practice, and I think all of us are very well aware and acquainted with the same. Next slide, please. So again, moving further ahead, what we need to understand is apart from platinum eligibility, how many patients respond to the treatment, how many patients can have some response on the treatment. Next slide, please. We will see in this slide here. So that is why this treatment got approval for PD-1, PD-L1 therapy in advanced cisplatin eligible patients who are PD-L1 positive. There were initially approval for all the patients, but later on a black box FDA label came, warning came that don't utilize platinum cisplatin immunotherapy in patients who are PD-L1 negative, because patients were having poorer responses and they were failing treatment very rapidly. So because the trial suggested for cisplatin eligible patient and not carboplatin, these got initial approval, but later based on the limited data and PD-L1 positivity, PD-L1 negative patients doing fairly poorer, the FDA black box warning came, and later the approval was changed to PD-L1 positive only. For pembrolizumab, it was PD-L1 CPS more than 10, and atezo, it was PDL more than 5% of the tumor area. Next slide. But still, we should understand the patients who are not fit for cisplatin but fit for carboplatin should be offered carboplatin, not immunotherapy directly, because the response rate are fairly poorer with immunotherapy first line treatment in metastatic urothelial cancer. So there have been 3 approaches. Wait and watch approach, as I have discussed. These are a lot of patients will not be able for next line of treatment. That is why this approach is out. Switch maintenance treatment, yes. Give chemotherapy, patients who respond or do not progress, utilize switch IO maintenance, and if progress, utilize next line of treatment. A continuation maintenance, for example, induction with IO, then followed by IO maintenance, and then utilize second line if progress. This has been also tried, but there is clear negative data for the same. Let's move to the next slide. So OS is limited by chemotherapy resistance, and we need to understand the main target of giving maintenance treatment is to sustain the responses which have been attained with the platinum based treatment, because immunotherapy per se does not have very high efficacy itself. But the main target of utilizing maintenance treatment is to maintain the response. Though there were some responses with avelumab that some patients have further downgrading of the tumor, and this has been our experience as well. So you can clearly understand from the data, median overall survival is to the tune of 15 months only, even who are patients who are fit for cisplatin based treatment, while for carboplatin is still lower by 1 to 2 months. Next slide. This is the various approach which I told. IO plus chemo from the first line induction. IMvigor data, no benefit for atezo addition to platinum. Pembro data with keynote 361, it was negative trial. Again, durva plus tremelimumab, negative trial, did not meet OS endpoints. That is why this approach is not considered further. Next slide. And other approach, which is switch maintenance, which I was just discussing, it is of fixed duration. Always having a switch to IO maintenance, patients will have the optimum outcomes, and this is what we are looking at. Next slide, please. So this approach which I just highlighted, switch maintenance, is a very, very important approach. We have learned it from the time of lung cancer, where we sometimes utilize switch maintenance, pemetrexed. For example, when we started patient on paclitaxel or gem carbo, we utilized maintenance with pemetrexed because pemetrexed maintenance is a fairly well tolerated treatment. Similarly, here there is an approach for improving overall survival using switch maintenance immunotherapy, which is a treatment which is not toxic to the patient. Patients can tolerate the treatment well, and that is why this approach is a very important approach, and we'll see the data in the next slide. Next slide. This is Javelin Barrier 100. This data is very well aware to every one of us now. This is this patient received 4 to 6 cycles of platinum based treatment. Both cisplatin or carboplatin were eligible. And patients who had CRPR or SD, that means those patients who had not progressed, were stratified to receive avelumab maintenance versus supportive care alone. And the best part of this trial had the primary endpoint of overall survival. We have got so many approvals based on PFS, and in even adjuvant setting based on DFS also. But here we have a data for metastatic setting, the primary endpoint is directly overall survival. So that is a beauty of this study. The trial design was such that the trial designers have a lot of confidence on the drug based on the activity, and they kept overall survival, which is a very hard endpoint, difficult to achieve endpoint for the study. And this was kept as a primary endpoint. Next slide. And just to highlight, a significant proportion of the around 368 out of 700, half were PD-L1 positive, but still less, around 50% were PD-L1 negative. Median age was 68 years. Yes, it is fitting into even our presentation. Our median age from TMH Mumbai data, it is around 60 years. Gender, 75% plus were males, rest were females. Performance status of 0 to 1. In the randomized trials, that is what happens. 0 to 1 were the maximum patient, all the patients included. PS2 were not included, but in real world setting, we include PS2 patients as well for this. Move to next slide. 50% patient receives cisplatin-based treatment. And if we see the overall survival, it is completely stumping, and it is supportive care alone. It is just 15 months, as we had discussed previously, and it is reaching to 24 months with avelumab addition as switch maintenance. And if we see the PFS data as well, for immunotherapy, again, I would like to highlight, PFS is not the best way to look at, especially the median PFS is not the way to look at. The way to look at is percentage surviving at a particular time point, for example, 1 year, 1.5 year, or 2 years. So we'd like to see PFS. It is median PFS is 2 versus 5.5 months. But if we see the percentage, it will give a better picture. At 2 years, it is 7% with supportive care alone versus close to 25% with supportive care alone. Similarly, at 3 years, it is 5 versus 15%. So yes, it is causing significant improvement, at least tripling of the survival at 1 year and even at 3 years. So yes, overall survivals are improved. Progression-free survival is also improved clearly from this data. Next slide, please. If we see the PD-L1 positive subset, it seems that these patients are getting somewhat more benefit. So it is very important. Prognostically, you can do PD-L1 to know how will be the prognosis, but all the patients are getting benefit because around 50% were PD-L1 positive, but 50% were PD-L1 negative as well. So it is not the PD-L1 positive subset which is driving the entire data, because when at least 50% patients are PD-L1 negative, you cannot have a driver of only from PD-L1. Next slide, please. This is about the safety profile. We are very well aware. The safety profile is well consistent. I am not going to detail. Only important point, some patients might have grade 1 or 2 infusion reactions. That is why I use pre-medication with Avil on all patients who are planned for avelumab, and then it is not a problem at all. Next slide. If we see the data, it is response is persistent irrespective whether the patient has complete response as well. So even the patients who had complete responses, the patients were have significant benefit to IO maintenance, because even the patients who are getting a complete response, they are going to have overall survival of 15 months to 16 months only. Don't think that patient had complete response to carboplatin or cisplatin based treatment, they are going to do very well. They will again relapse very fast, and therefore it is wise and good enough to utilize IO maintenance if feasible. Next slide. This is the data by the number of cycles. Again, a very important point which I would just like to highlight. Patients, what happens in the real practice is that after 3 to 4 cycles, we see a lot of patients developing significant amount of thrombocytopenia, especially because we are forced to use carboplatin in a lot more patients. Carboplatin is known to cause more amount of cumulative thrombocytopenia through the cycles. So what happens towards the end of the cycle, if you are stretching to reach 6 cycles, what happens? Patients tend to lose the dose intensity of the treatment, and that is the time when patients can progress on the treatment even while on chemotherapy. That is why after 4 cycles, if it is fine, patient had already good responses, I will try to switch to IO maintenance, avelumab maintenance, and not wait for completing 6 cycles, because a lot in real world, what happens, a lot more patients tend to develop poor dose intensity, and they can rapidly progress in that time. That is why switching to correct treatment at the correct time is also very important. Next slide. This is the overall survival data, irrespective of duration of treatment-free induction before maintenance. So yes, if we start it from below 6 weeks, between 6 to 8 weeks, or 8 to 10 weeks, in all the subgroups, it is seeming to benefit. And the preferred time in my real practice around 4 to 6 weeks. However, it can be utilized even up to 10 weeks in the real practice. Next slide. This is Asian subgroup analysis. I will just rush through it. There were a significant number of 150 patients from the Asian subgroup with primary endpoint of similar overall survival. And next slide. Again, a significant benefit you can clearly see, 18 months versus 25 months. The data is set as small. That is why you can see curves initially separating, but later what somewhat merging, but still it is important to be statistically significant. Next slide. And the guidelines clearly suggest, both ESMO and NCCN and European Union guidelines clearly say utilize avelumab maintenance irrespective of you have utilized GEM-CIS, you utilize GEM-CARBO, DD-MVAC or MVAC, utilize IO maintenance in all your patients if the patient did not have progressive disease on the treatment. So guidelines are very clear. Next slide. So this is a post checkpoint inhibitor also. This is the second line treatment options. The options are huge, and which we will be discussing in the further presentations, which include erdafitinib, using paclitaxel or docetaxel in the real scenario. Patient who did not get exposed to gemcitabine will be getting the same. Next slide. And this is what a very important point I would like to highlight. The patients who were receiving were in the supportive care alone arm. A large number of the patients received immunotherapy in the second line treatment. So that is a very important point to be mentioned, because when the patients are progressing and the patient are still eligible for receiving some form of treatment, a large number of patients are able to receive immunotherapy in the next line, which is the standard of care. Still, the survival benefit was there with avelumab maintenance. So that again seals the confidence in the drug. And the patients who had progressed after 6 months of platinum-based treatment, re-challenge with platinum-based treatment seems to be the most effective treatment, and that is what is happening in this subset. Next slide. And this is the survival by the second line treatment I just highlighted. Patients receiving re-challenge with platinum after 6 months and having best possible survival. Next slide.
My apologies, sir. You need to conclude your presentation. Only 2 minutes, sir.
No, I can go directly to the conclusion slide now. This is the long-term data from enfortumab vedotin. This is also clearly suggesting this upcoming data, and enfortumab hopefully will be available to us in the next 6 to 8 months. So this is a good data, especially for platinum ineligible patients where platinum is not at all option. So the data seems to good. Next slide. Please come to the conclusion slide. Yeah, these are the various data sets in the subgroups, and this is what we need to look at, constantly update. So to conclude, avelumab maintenance is the standard of care option in patients who have not progressed on the platinum-based treatment and should be utilized in all the patients. And I prefer to shift it to IO maintenance after 4 cycles of GEM-CARBO. If patient is fit enough to receive GEM-CIS, I think they can go up to 5 to 6 cycles. But anytime if you find delay in the maintaining dose intensity, you can directly shift to avelumab maintenance without waiting for immunotherapy toxicities, chemotherapy toxicities to recover. With this, I end here. Thank you for the patient listening.
Yeah, thank you, Dr. Akhil. You were wonderful, and your talk was explanatory and just removing our confusions. So next I will invite our Dr.